Hello, I'm Donal McCauley, and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Colorado, and I'm talking to Jack Westfall. Jack, you've had a fascinating career from the high plains to the big cities. Tell us a little bit about your career trajectory.
So I'm Jack Westfall. I'm a family doctor. I grew up in rural Colorado, went to the University of Kansas for medical school, and then back to Colorado for residency. Joined the faculty um, and was in the residency, and really got an hankering to go back to rural. And so I talked to a couple of my friends, and they said, "Well, come practice half-time in rural." So I started doing that, and then one of my mentors, Dr. Larry Green, had been working in a practice-based research network, a PBRN, and said, maybe a rural PBRN. And so we started in 1997, the High Plains Research Network. Started with 6 counties. It's grown to 16 counties. It's essentially a practice and community-based geographic practice-based research network. That is 16 counties. It's 250 or 300 miles end to end, 180 miles wide. It's 55 primary care practices. They all participate. 16 small critical access hospitals, anywhere from 5 to 10 beds, a couple of larger hospitals with 30 to 40 beds. And then it's run by and led by community members. Participatory research has been a part of our culture and our thinking since early on. First, we engaged the practices, and then we were missing a voice. And about 2003, we realized that while we were getting good information from the practices, what we really needed also was voice from the community. So we started a community advisory council of farmers and ranchers and school teachers and students. And they've been with us for 20 years now. Started in 2004, and they're still with us. There's several that have been there the whole 20 years. Um, so we did that, and then that grew because the university got a big NIH grant, a CTSA, Clinical Translational Science Award, and it needed to have some sort of community engagement. And so we added in several of Colorado's practice-based research networks, and I had the good fortune of being the director of the Community Engagement Corps for our CTSA for a number of years, where we were able to stabilize the engagement out in the community using community liaisons. And we had some in rural, and we had some in urban. We had some on the eastern slope and the western slope. I also was the associate dean for rural health because rural's in my blood. That's one of my things. I grew up in a small town. I worked in a small town, and I really appreciate the hard work. And I continue to work a day a week in my hometown, Yuma, Colorado, a town of 2,000 people with a small hospital and clinic. Then I got lured away to Washington, D.C. to do some policy work. I'd done a little bit of health
Uh,
service research and
Let me
sorry.
stop you there, Jack, just for a
Yeah,
moment,
yeah, yeah.
because I'm really interested in this community engagement. Tell us how the community engagement works. How do you get the people to contribute?
Yeah. So, community, how do you do community engagement? Well, we have a little saying, and we wrote it down, and it's essentially you go talk to some people and you listen to them. And then you think about that. And then you go and you listen to them again. So the typical has been helicoptering in, researchers come in, they listen once. And the first time, community members tend to tell you what they think you want to hear. What do you need? Oh, we need better healthcare access. We need more primary care. We need cheaper drugs. But then when you go back and listen again, and you actually start having meals, and you start spending time, and you start building relationship, then you learn what they really need. They need transportation. They need community support. They need jobs. Um, they also need healthcare, but they think of healthcare in a very integrated sense. That is both the clinic and the hospital, but also what's going on out in the community. And so then I think in our saying, in our little one paragraph, there's a listen again, a third time. And so it's about listening, building relationship, and then the big crucial part, sharing power, money, priorities. This isn't just about me as a researcher, what I want, it's what the community wants. We have another saying. We were in a meeting one time, and this was early on, first 2 or 3 years, and we were going through some paperwork and thinking about data use agreements and who owned the data and paperwork and conflicts of interest. And the community members were getting agitated. It was not going well. And Jack was on a roll, and I was preaching the gospel of data use. And finally, this old farmer, Gary Haynes, stood up and he crossed his arms like this. And he said, "Okay, Westfall, here's the deal. As long as this work is about the community, about rural Colorado, and helps the people in my community, I'll stay involved. But as soon as this becomes about you or the university or some paper, I'm out of here." And everybody stood up, they all clapped, and we put all the paper away. And we now go by something we still call, 17 years later, the Gary Haynes ethic. And we make decisions based on what the community wants. Ann Macaulay came out to the rural Colorado and said to the community members, I'm going to say this in front of Jack, the community is always right. Oh, so we try to live by that. And, we look around every year or so and say, who else isn't at the table? Who do we need? So that community engagement is a key to the High Plains Research Network. It's a key to my work. I can't imagine doing work without asking community members and patients their experiences and for their expertise.
So how does that translate into the research directly? Do you go to the community for ideas? Do you float the ideas with the community? How does that work in practice?
So it's both those. So we've had a couple of strategic planning sessions, and we learn about what's going on in rural Colorado. What are the priorities? What are the health conditions? We listen to people that have data and people who have stories. Data and stories together are fantastic. And then the group comes up with sort of their top 10 or 12 list of here's the priorities. We want to talk about asthma, COPD. We want to talk about mental health. But then sometimes a funder says, hey, we want to fund something on colon cancer prevention. And so then we go to the community and say, hey, Centers for Disease Control in the United States has a new grant for rural colon cancer prevention. What do you think? And if they say, no, we're not for that, then we would move on. But sometimes they say, oh yeah, that's awesome. We'd love to do that. So we have a combination of ideas that come up through the community, ideas that come up from the practices, diabetes and hypertension and vitamin D deficiency, things that come up from the practice and the clinicians, and then things that come from the funders that we vet through the patients and the community members. And so, for instance, we did this project on colon cancer prevention that was funded by the Centers for Disease Control, and it was quite fun. And they named it the Got Polyps campaign, and they produced a lot of cool materials. And we got done with that one, and they said, okay, that's awesome. Now, asthma is a huge issue, and lots of young families have kids with asthma, and they don't know what to do. And we have young people who stop doing their sports or their agricultural stuff because they have asthma. What can we do about asthma? And so we spent a year or so learning about asthma and then finding a grant. And we had over 700 community members participate in the rollout of that through the community colleges, through high schools, through the radio, through all sorts of venues where we got the word out about asthma using local community voices. And those were identical to the messages that were in the clinics. So there wasn't this disconnect between what was going on in the community and the practice. All of that was integrated. And That's one of the things that the High Plains Research Network and the Community Advisory Council have taught me, is that if you intervene in the practice, that may be helpful. But if community members and patients don't understand the same language, it's only partially. Same if you do a public health thing and you do messages into public health, but you don't get into the practice. When the patients go into the practice, they may hear something different. So you really have to integrate those.
Now, there's something I'd like to ask you about because it really caught my imagination, and that is about the language you use in your research. And that was, talk to me about colorectal screening, translating that into practical language.
Oh my gosh. So when we did this with colorectal cancer screening, the title of this from the CDC was um, uh, Improving Prevention for Colorectal Cancer Screening Amongst Hispanic and Non-Hispanic Males and Females in Rural Communities. That was the title. And our community members, like they were like, "What the heck is that? What's screening? And what's do we have to use the word rectal? Can we just say colon?" And so they went through this process where they spent a half day, 4 hours learning all about colon cancer. And then they decided to change the words. They said, screening, that may mean something to you, but that doesn't mean anything to us. Are you talking about doing a test, like a blood test or colonoscopy or a fecal occult, some sort of test? Can we just call it testing? And oh, by the way, let's just call it colon. So they changed the name to Testing to Prevent Colon Cancer. And that was a game changer. People suddenly started accessing these messages because it was using common language, locally relevant, actionable messages. Hey, go talk to your practice, go talk to your primary care clinician about this. And so then they said, well, that worked so well with colon cancer, let's do it with asthma. And they did the same thing with asthma, translating those complex guidelines from the National Lung Association into something that was meaningful and relevant to them.
Now, let me bring you back to the bright lights of the city because you did some more work centrally.
Yeah, so, my wife's a neurologist. She worked at the university and at the VA, and we raised our kids in Denver. I always did my clinical work in rural, but we lived in Denver. And so when I was at the university, which is an urban university, I became the director of the Clinical Translational Science Community Engagement Corps. And then I also was working with a lot of faculty doing health service research. So there was a number of things there. And I think, the urban was always interesting, but only in as much as we could engage the communities in urban as well. So we were able, there's a lot of both geographic, racial, and ethnic LGBTQ communities within Denver and the metro area that are important to include in any of the work we do, but that all have various needs and messages and constructs around the healthcare issues that they're facing. So we were able to expand sort of the stuff we'd done in rural Colorado and engage urban communities as well. Now, I will say, once I started doing the health service research and did a little bit of policy work, I started flirting with the policy world, and we ran off to Washington, D.C. for a few years to do some policy work. And that was probably more hubris than anything. But we spent 3 years there. It was tough. The weather was tough. The job was tough. And we felt the call of Colorado, and my wife's parents were aging. And so we've moved back to Colorado.
Let me ask you a little bit about that policy work, because I found that quite interesting as well, because you worked with the Robert Graham Center and you worked on quality. Tell me about that.
The work with the Robert Graham Center was fascinating because the goal was to create and curate evidence that informed policies that support family medicine and primary care. So, actually, when I went to the Graham Center, I thought the Graham Center was a policy center. It's really not. It's an evidence center. It's a data center. We create evidence to inform policies. And there's other people who do the policy work. And that was a real important lesson to think about in terms of what does primary care research do? And do we do policy, or do we create and curate evidence to inform policy? There were some studies that came out that showed family doctors didn't have as high a quality for heart attacks. Well, when you actually read the study, they excluded so many patients that family docs take care of that it was not, you couldn't even really tell. But there's an editorial opinion by many of the East Coast journals that family medicine is not as smart or as good as some of the other specialties. So quality is really tough. And it's one of those paradoxes where for many individual diseases, diabetes, heart disease, lipid control, family doctors may have lower quality scores for an individual disorder or disease or condition. But when you look at the health overall, patients live longer, they cost less, they're happier than if taken care of solely by specialists. There was a really nice study that came out a number of years ago that we tried to replicate over and over and tried to find places to do this, but it showed actually the best outcomes for heart attack were in patients who were cared for by both a primary care clinician and a cardiologist. They had better 1-year survival than patients cared for by just a cardiologist or just the family doctor. And I think that really gets at the core of what family medicine does. We take care of people over time. We know some of the competing demands. And so we did quite a bit of work in the High Plains on competing demands, patients with diabetes, but also with COPD and hypertension. And how do you take into consideration each of the various complex conditions rather than just measure 1, 2, 3? And so that quality is real important. I really like Barbara Starfield's work on the 4 C's: continuity, comprehensiveness, collaboration, first access. And I think that continuity and comprehensiveness are 2 of those measures that there's the Graham Center is still studying, as is the Center for Professionalism and Value at the ABFM. They're studying these because I think that comprehensive and continuity are really crucial to understanding that paradox, because we know so much about our patients and we learn about their values and we learn about what matters to them in such a way that both they have a rich, thriving life, but they also have a successful end of life.
You've used a line that relates to those issues of quality, and that is that patients are more complex than a single guideline.
Yeah. Yeah, I think I crave the day when funding agencies and academic researchers are required to consider this in everything they do, because this is the day-to-day work of family medicine. They don't just see a diabetic. They don't just see a hypertensive or an asthmatic. They see a human in a context of a family, or with a significant other, or a job, or isolated. And all of those conditions, and both social conditions, personal conditions, and values impact their outcomes. What do you want out of the next 5, 10, 20, 30 years of your life? What do you want to be able to do? And what a valuable question to ask, because this gets at the complexity and the treatment in an individual rather than as a disease. It's, hey, Mr. Jones, you have these 3 conditions. Here's the treatment options for each of those. What do you want out of the next 10 years of your life? Oh, you know what? I want to be able to continue to drive a tractor. I had an 82-year-old last week who was like, you know what, Jack? I may have to do something about my knees because I can't get into, it hurts to get into the tractor. 82, still driving a tractor. But I have others who say, all I want to do is be able to pick up my grandkids. I'm done working. I want to be able to go hang out with my grandkids. I want to be able to go to a football game and climb up the stairs to see my grandson play quarterback. So that complexity is relevant at the individual level so strongly rather than a set of diseases or a set of conditions.
That's the most elegant description I've heard in practical terms of what everybody uses the jargon for patient-centered outcomes. Jack, it's been just a pleasure talking to you. Thank you very much indeed. It's just
Thank you so
wonderful.
much. I really appreciate it.